Now we will start EVA Symposium. The speaker is Dr. Khalid Al-Husseini. Professor Khalid Al-Husseini, Professor of Al-Shamsi University, Clinical Oncology. The topic will be a role of anti-angiogenic drugs as second-line therapy in the landscape of metastatic HCC. Please, Dr. Khalid.
Bismillah ar-Rahman ar-Rahim. I'm greatly honored to be the Pharma group who gave me the chance to present this talk about HCC second line. HCC is a major health problem in Egypt, as shown in Global 2020, where it lies in the first higher incidence, exceeding that of breast and lung new cases in both sex. HCC being not a single disease, being always associated or accompanying post-viral cirrhosis, so it is two diseases in one person. So management of HCC almost always should be accompanied in an MDT, including hepatology, hepatic surgery, interventional radiology, medical oncology, and pathology and palliative care. Because HCC cases should be managed after three pillars of assessment: to assess the child post-code for cirrhosis, to assess the echo performance status of the patient, and to stratify the tumor burden according to the BCLC staging. This BCLC staging that stratify patients including the three main items with the resultant treatment options that has a very wide spectrum from curative surgery for ablative measures to systemic palliative treatment, with the intervening in between the gray zone that may result or may move to either systemic treatment or to bridging to a radical curative treatment. This is the ESMO guideline for management of HCC. Every single patient with HCC, all of us do for him alpha-fetoprotein either in the diagnosis or in the follow-up to assess treatment response. But this is not only the value of alpha-fetoprotein, because alpha-fetoprotein is associated with a correlation with survival, as the higher alpha-fetoprotein level is associated with poorer outcome. And a threshold level of 400 milligram per milliliter is defined as above which poorer prognosis is encountered and below which relative better prognosis is. This may be due to alpha-fetoprotein correlation with the expression of VGF and VGFR2 in HCC cells, where financing the alpha-fetoprotein through silencing RNA can reduce the expression of VGF and VGFR. This correlation between a high level of alpha-fetoprotein and high expression of VGF-VGFR2 can express the association between the aggressiveness of high expression of VGFR2 and the aggressiveness of HCC. This raise the rationale of blocking VGFR2 can result in clinical models can result in reduction of tumor angiogenesis and the reduction of migration of human cells and the reverse resistance of HCC cells to apoptosis. There is a wide spectrum of management of HCC in the second line, but it is narrow in the first line, slowly progressing through the last 20 years, but accelerated in the last 6 or 7 years in the era of immune therapy. While treatment in the first line stopped in HCC, either due to the magnitude of response or the narrow spectrum of duration of response, it would be more hard or more tough in the second line due to the same causes and also due to exhaustion of the patient in the first line or another portion in our country due to the financial issue. Regarding the second line treatment, we have regorafenib as approved in the resource trial, in a phase 3 trial, testing regorafenib versus placebo in patients with HCC after progression on sorafenib or intolerability, selecting patients with child A and advanced HCC, and the endpoint was overall survival, and fortunately enough, it met its endpoint, and median survival benefit was achieved 10.6 versus 7.8 in the placebo arm. Similar findings achieved with cabozantinib in celestial trial, testing cabozantinib versus placebo in advanced HCC after progression on sorafenib in compensated child A patients. It also met its endpoint and achieved a median survival benefit 10.2 months versus 8 months. The third player in this setting is Ramo, which blocks the VGFR2 receptor and its ligands, thus preventing angiogenesis and tumor progression. It was first tested in Reach trial 2015, where patients were assigned to receive ramucirumab versus placebo in patients previously treated with sorafenib advanced HCC child A. Unfortunately, in the intention to treat population, no survival gain was achieved, while subgroup analysis revealed survival advantage in only those with baseline high alpha-fetoprotein above 400 nanograms per ml. in the intention to feed population, no survival gain, while with the increasing level of alpha T2 that we can translate it to higher proportion of the target of the drug, with the increasing proportion of alpha T2 level, separation of the curve of care and survival gain could be achieved. This made the way for REACH-2 trial in 2019 when Ramo was compared to placebo only in this group of patients with baseline alpha-fetoprotein 400 or more. The primary endpoint was overall survival, and it achieved its endpoint with a survival gain that become more apparent when the curve goes down, where the survival rate is 24% versus 11% at 1.5 years. Subgroup analysis revealed the same benefit in all subgroups, and the adverse events, there is no red flags except that well known for anti-angiogenesis with hypertension grade 3 in 12%, hemorrhagic events, GI hemorrhagic events in 5%. The pooled analysis that gathered REACH and REACH2, the REACH only the subgroup of alpha T2 400 or more and the REACH2 group. The pooled analysis of both reveal median overall survival of 8 months versus 5 months and disease control rate of 56% versus 37% in the placebo arm. Also, for REACH and the pooled analysis of REACH and REACH2, consistent, non-different pattern of adverse events was encountered, the same percent of grade 3 hypertension and proteinuria. Subgroup analysis also in REACH2 revealed that Ramo for patients intolerant to sorafenib is more beneficial than those for patients progressing on sorafenib. And also for non-viral cirrhosis, it was also more beneficial than viral cirrhosis, while the benefit was observed in both. And the magnitude of the benefit increases with increase of alpha T2 protein. This made the way also to expand use of ramucirumab in patients with non-sorafenib based systemic therapy, where these group of patients were assigned to receive ramucirumab after 1 or 2 prior lines, neither of them is sorafenib. It is one-arm study and the treatment continue until disease progression or unacceptable toxicity. 47 patients entered the trial. 20 of them received lenvatinib. About 10 patients received a single agent immune and the other combinations. The median time to radiologic progression was 2.8 months. The number of patients achieving an objective response was about 10%, a considerable percent as a third line, with a median duration of response of 8 months. Survival was observed to be longer in patients with alpha-fetoprotein response, where it was 10.7 versus 5.6. Pooled analysis for ramucirumab expansion cohort versus ramucirumab field analysis in REACH and REACH2 reveal consistent survival gain of median overall survival of more than 8 months versus 5 months in the placebo arm. For this cohort, ramucirumab demonstrated consistent, meaningful clinical activity with no new safety signal following non-therapeutic therapies in patients with advanced HCC with alpha T2 more than 400 nanogram per milliliter. And this represents one of the first sequencing studies for patients with advanced HCC not treated with therapy. So in the second line, we always go for the effective drug, but in HCC, you have to go not only for the effective drug, but also to the tolerable drug. So, while we have 3 agents proved effective in a phase 3 trials, you have to revise the toxicity or the adverse event criteria in these 3 patients, 3 arms to tailor your treatment choice to your patient. Always we have to remember that alpha-fetoprotein is a prognostic marker for more aggressive HCC. We have to remember that high baseline alpha-feto of 400 and more is a good predictor marker to have overall survival benefit from ramucirumab. Ramucirumab is also well tolerated with effective profile consistent with monotherapy ramucirumab treatment and least toxic approved second line. REACH2 is the first positive study in biomarker selected patients. Biomarker selected patient population based on alpha-fetoprotein level above 400. Ramucirumab also resulted in a better giving ramucirumab results are better given upon a sorafenib intolerance rather than waiting for its progression. Thank you.
Thank you, Professor Khalid, for your elegant presentation. And the floor is open for any questions. Professor Dr. Lubna? Mike?
Dr. Khalid, as usual, a very interesting presentation. My question related to, do you have any explanation that those patients with high alpha-fetoprotein, especially the cutoff 400, achieved a good benefit from RAM rather than the other group? This is the first. The second question related with the introduction of RAM, we have to assess esophageal varices before administration to see the grade of varices is considered as a contraindication.
First, the differential response of those with higher alpha-fetoprotein would be attributed to the higher proportion of expression of the target of the drug, higher proportion of expression of TGF in those with elevated alpha-fetoprotein blood pressure. So, the target of the drug is well presented, so you can expect more. As regards the second portion, yes, we have to monitor the feeding tendency of the patient. We have to map or treat in their visual therapy before starting.
Dr. Khalid, my question for you, the REACH trial and the Celestial trial and all second-line trials were after progression on sorafenib. Now we have a new standard of care in first-line metastatic HCC. We have atezolizumab, we have durva, tremi, and so on. Do you think we need phase 3 trials, or we can how can we sequence the treatment options, especially that we have new first-line agents and all the trials were after progression on sorafenib?
We don't have this trial to assess or to plan exactly combined step photography and Pharma. And for other options, we have to do this. We have to do phase 3 trials. We only have to do or new post-immune. Yes, we have these 2 trials, but none.
Thank you, Professor Khaled, for your explanation. Do we have any questions? I think we. Thank you, Professor Khaled, for your presentation.
Now we'll move for the second talk in this session. It will be presented by Professor Hagar Al-Ghazawi, Professor of Clinical Oncology at Shams University. The well-established benefit of adding abemaciclib to the adjuvant treatment in high-risk HR-positive, HER2-negative breast cancer.
Thank you, Dr. Ahmed, and good evening, everybody. I am pleased to introduce this topic today, the well-established benefit of adding abemaciclib to the adjuvant treatment in those with high-risk hormonal receptor HER2-negative early breast cancer. I promise that I will be as fast and as pointing for the important points as I can. So as we know that breast cancer is the most common malignancy in worldwide and in Egypt. In this meta-analysis, I was honored to participate in. We tried to explore the clinical pathological features of breast cancer in Egypt. Till 2015, it included more than 30,000 patients with breast cancer. Actually, we found that there is a dominance of advanced stage and young age diagnosis in Egypt. This is the main 2 features here. And collectively, stage 2 and stage 3 accounted for 70% of the patients, and the HER2 positive and triple negative to around 30% of the patients. So as we know that hormonal receptor positive HER2 negative is the most common subtype of early breast cancer, and despite advances in the endocrine therapy and the systemic therapy, we still have a high-risk population with 20 to 30% risk of relapse. So how to identify those patients with high risk of relapse? There are actually many factors that affect the risk of relapse. We have the grade 3, the high T67, the high recurrence scores, and other factors. But the cornerstone for the high risk of relapse is the nodal burden. The lymph nodes N1 versus N2 versus N3, this represents the major significant factor that correlates with the risk of relapse. As we see here on the right side, this is the figure from the EBCC meta-analysis, very well known, including more than 70,000 patients. At 5 years, if you see here, at 5 years, we have a risk of relapse more than 20% in those with N2 disease. Also, regarding the mortality, we have the data from the US SEER database, retrospective data. That the higher mortality rate correlates or associated with the patients with 4 or more positive lymph nodes, grade 3 and the grade tumor type. So all we have mentioned give us the rationale to design the CDK4/6 inhibitors clinical trials in the early setting of hormonal receptor positive, HER2 negative. Actually, we have the four main studies, the Penelope, the Palace, which included or covered the first year and the first 2 years of the endocrine treatment with palbociclib, and the Monarch E covered the first 2 years with Abema, and the Natalie the first 3 years with the ribociclib. Of course, there were many differences in the inclusion criteria, where all included those with node-positive disease, and the Natalie included those with high-risk node-negative disease. For the Palbo, it was in negative studies in both the trials, but the Monarch E in the abemaciclib, it was the only approved, FDA approved and EMA approved with high or long-term follow-up results till now, as I will mention shortly. And it included the patients with 4 lymph nodes positive or 1 to 3 lymph nodes with grade 3 or T3 and or high T67. And we are still awaiting the results, long-term follow-up results for the Natalie. Going specifically for the Monarch E, it included the patients with the cohort 1, depending on the high-risk clinical pathological features, as I mentioned before, and a small cohort that started later on after 1 year, included those patients based only on the high T67, randomizing the patients to either Abema or the standard of care endocrine treatment. And primary objective is the invasive disease-free survival with a very strong, considered very strong endpoint, and secondary objectives of the disease-free survival, overall survival, and safety and other endpoints. The baseline characteristics were well balanced between the two arms. And for the results, still a few days ago in the last ESMO, Professor Nadia Harbet presented the final result, or the third interim analysis result, where all the patients had finished the abemaciclib 2 years, and 80% of the patients were followed to more 2 years after the completion of the abema. Actually, there was a sustained invasive disease-free survival benefit in the ITT population. We can see the very nice separation of the curve, starting 2 years after, directly after completion of the abema, and continuing for more than 5 years. This was translated to a hazard ratio of 0.68 and translated to 32% reduction in the risk of developing invasive disease-free survival events, with an absolute difference of 7.6, which is considered a very impressive number. Also, there is sustained distant relapse-free survival benefit in the ITT population. Again, there is a very nice separation of the curve, translating into 32.5% reduction in the risk of distant relapse. For the overall survival, we are still awaiting the final overall survival data, but as we can see here, that the curves are overlapping, but we can see a slight separation of the curve at the end of the 5 years. Also, there is numerical difference in the deaths due to breast cancer. If you can see here the blue color representing the deaths due to breast cancer, it is slightly larger in those endocrine treatment only. So if we can go deeper to the subgroup analysis, there is consistent invasive disease-free survival benefit observed in the all selected subgroups, apart from the age, the number of lymph nodes, the grade, and the setting of the chemotherapy. An important point that we should all know, that even though those patients who received the neoadjuvant chemotherapy, this was published the last year in a separate publication, they consisted about 37% of the whole population. Those patients received neoadjuvant chemo, also gained the benefit from adding the adjuvant abema, even with a higher benefit rate, with a hazard ratio of 0.39, translating to about 40% reduction in the risk of relapse. This comes to an important point, or we should highlight an important point here, that before receiving the neoadjuvant chemotherapy, we should make a proper assessment for the axillary lymph nodes to account for the proper staging to properly stratify the patient for the risk of relapse. Also going to deeper to the cohort 1, as we mentioned, it is based on the clinical pathological factors. Patients with high Ki67 had the same magnitude of benefit as patients with low Ki67. For the safety data, there was no new safety signals in the latest update and compared to the prior report. But we have a small note here that the treatment discontinuation rate was about 5% compared to the metastatic setting. Actually, this is not a very large difference, but it highlighted to us that the patients are at low tolerance in the adjuvant setting to tolerate even though those with grade 1 or 2 toxicity. So they have higher tendency to discontinue treatment even for lower grade of toxicity. Regarding the patient-reported outcomes, Professor Nadia Harbeck also reported this and presented this in the last ESMO breast. There was equal or similar scores between the two arms, indicating that the quality of life was preserved in those receiving the abemaciclib. So what about the age subgroup? Is there any, there is a logic question, if there is any difference in the efficacy in those elderly receiving the abemaciclib. Actually, according to the latest data, patients with more than 65 years have the same magnitude of benefit like younger patients. Of course, as expected, there was some numerically higher discontinuation rates and interruptions and reductions in those with elderly, but this did not impact the final survival data. Here we can see the curve of the 3 dose levels, the complete dose and the first dose level reduction, 30%, and the second dose level reduction with 60% dose reduction. We can see that the 3 curves are overlapping, and this does not impact the invasive disease-free survival. So the takeaway home message today that the only approved CDK4/6 inhibitor, which is approved with mature results in the adjuvant setting, is the abemaciclib with a very significant invasive disease-free survival, and which increased with time approaching the 5 years. And this is was with tolerable and reversible toxicity profile. Thank you.
Thank you, Professor Hagar, for this elegant presentation. The floor is open for questions. Dr. Alameddin. Can you please hand the mic here? Mic here for Professor.
Thank you, Dr. Hagar, for the presentation and for the data. And my question is, as you know, in the NATALY trial, they used the recurrence score to select or to better select the patient for the high risk who might benefit from the addition of CD4/6 inhibitors as an adjuvant. Would you think that in the context of the Monarch E trial, I mean, should we go again to this trial and then do the recurrence score for the patient and then redefine the high risk group rather than the clinical pathological factor?
I think this is the intelligent question, Dr. Muhammad, that you know, in the Monarch E, they smartly selected the patients who had the highest risk of recurrence, which are mainly the N2 disease and N1 with some additional risk factors. So if you included those subgroups with N2, they are out of the scope to test their recurrence score with any genomic assay. But those with 1 to 3 and another risk factor, I think it is logic we can make this hypothesis, but without the need to this, only depending on the clinical pathological factors, I think we have a very good and nice data, long-term follow-up data for invasive disease-free survival, and we are waiting for the overall survival.
Thank you, Professor Dr. Hagar, for your presentation. I have a question regarding hormone receptor positive, HER2 negative breast cancer. If with high risk features, and if the patient has BRCA mutation, how is the sequence? Because now, who is the patient who needs both drugs, or can we start with a drug because the other? How to sequence this condition? High risk features, hormone receptor positive, HER2 negative, and at the same time BRCA mutation.
This is a common and basic question, but هقول لك حاجه احنا عندنا two categories to be eligible كهرمونال receptor positive HER2 negative, to be eligible adjuvantly, not to adjuvantly to the PARP inhibitors. You, according to the Olympia, you have to have hormone activity. This is the adjuvant category. So this patient, hormonal receptor positive, HER2 negative, you have the both data from here and here. I think in the monarchy E, we don't have the data from according to the BRCA status, and in the Olympia, you don't have the data for except they were included in 20%. So if I have the chance for those high risk patients, I will prepare the targeted therapy, and we have some like retrospective or theoretical data. It is gaining more and more accumulating evidence that CDK4/6 inhibitors may have less sensitivity in those with BRCA status mutation. So I will prepare those, but I will consider in very, very high risk the sequential.
So we cannot combine abemaciclib and olaparib at the same time because the high toxicity.
Data for both.
Yes.
No safety data for both combination in the same time, but sequentially, some guidelines may consider sequentially in those with high very risk.
So if you sequence the treatment, what treatment will you start?
1 year, olaparib.
Perfect.
1 year,
yes.
then the 2 years.
Yes. Thank you, Dr. Hagar. Thank you. And now we close the session.